non for medical advancement. So we have closed captions on to accommodate students' needs. If you have any more ideas on how to make this more accessible, please contact us at this email. Please also follow our Instagram or TikTok if you want to hear more updates about our organization and possible meetings. So I'm calling from Brooklyn, New York, and you guys are all across the world. So in the chat, if you don't mind, please tell me where you guys are from.
Perfect. We have from New York, we have Georgia, we have Michigan, New Jersey. Welcome, everybody.
Yeah, okay. So if you guys want to get more involved in this organization, you guys can sign up through these two links. We're also recruiting for our leadership team. So if you're interested, please join up. So some leadership roles we have with PHS are like lead a fundraising, lead a research program. You guys can sign up through this link, and yeah. If you're a high school student like me, we're offering a HTP program. You guys can learn more about leadership and healthcare education like this to make it accessible to anyone across the world. The link is over here if you'd like to join. And if you want to, you can donate. This organization is a nonprofit. We don't take any payment. Like, we don't charge anyone for these meetings. It's all free and voluntary. So if you would like to, you can donate. Do you guys have any questions? If you do, please put them in the chat. And our goal.
Vincent, I think you're muted right now. Thank you.
Oh, sorry. So make sure to take good notes because our post-shattering assessment will be available at the end to earn your digital certificate to verify your hours. And if you like, please turn on your cameras because although this is virtual, it's nice to have like a community and stuff. So yeah. And that's it. So so I'll let our professionals speak and make sure to take good notes.
Perfect. Thank you, Vanessa. And we're going to go ahead and welcome our professional for being here with us today.
Hi, everyone. My name is Janice Firn. I'm a clinical ethicist. So I can talk a little bit more about what that is and happy to take questions. So I have an example of a presentation that I give when I'm talking about what is ethics and some of the concepts that are in bioethics. I'm at the University of Michigan, so you'll see some of that in the Bioethics Center that I'm a part of on my slides. But so format-wise, if you've been here before, then you know, but if you're new, I'm going to give a presentation for about 45 minutes, and then we'll have opportunity for everybody to ask questions. I'm going to share some slides, so if you want to keep your camera off while we're doing that, but when we come back for a discussion, would love to have people, if you're comfortable in a place where you can do that, have your camera on and understand that that doesn't work for everybody. If you have a question along the way, if you want to type it into the chat, I'll keep an eye on those. And then also, like I said, if you're more comfortable saving it at the end. So we'll get started here. I'm going to share my slides. All right. So as I said, I'm an associate professor with the Department of Learning Health Sciences at the University of Michigan and an ethics educator. And today I'm going to talk about ethics, professionalism, and medical decision making. All right. I don't have any financial or other conflicts of interest to disclose related to this material. So for an outline tonight, we're going to talk generally about professional obligations and then medical decision making, some ethical frameworks for that. And I'm going to briefly touch on ethics consultation as part of this presentation, but I'm happy to go into much more detail as folks have questions after. All right, to get us started, I'm going to start with a case example. And just because depending on accessibility or screen size and things, it may be hard to see, so I'm going to read the case. Amy is a 19-year-old sophomore at the University of Michigan who presents to the emergency room with severe abdominal pain. She's diagnosed with an ectopic pregnancy that is in danger of rupturing a fallopian tube and requires emergency surgery. Once the medical facts are discussed in detail, she signs the consent form. She contacts her parents to let them know that she's in the hospital due to abdominal pain, but does not tell them about the pregnancy. She pleads with the team to do whatever is necessary to help her, but to not tell her parents about the pregnancy because, quote, they would kill me, quote. Surgery is complicated by severe bleeding. She's critically ill afterwards and on a mechanical ventilator and sedated in the ICU, in the intensive care unit. Her parents and brother arrive, shocked and scared and wondering why Amy is so sick. And you can put yourself in the shoes of maybe the nurse at the bedside or the respiratory therapist. Maybe you're the intern, the junior doctor on the service, or the social worker. You can pick who you are on the team. Then you're being asked what's happening. We're really scared. But on the other hand, you have Amy who said some limits to what kinds of information she wants shared with her family. So what do you tell them? All right, let's take a step back and talk a bit about professionalism, and then we'll come back to the case at the end. And there'll be opportunities for some participation here, and I'll ask you to throw some things into the chat when we get to those slides. All right, so what does it mean to be a professional? Well, traditionally that meant to take a vow or make an oath. And those professions that we think of, the sort of original professions, would have been like law or medicine. But now it's much broader, and we think of many different professions that are involved in health and healthcare. But professions have specific roles, and one of their roles is that they possess a body of knowledge. So to be a social worker, for example, you have to go to a school that is certified by the Board of Social Work, right, to provide content that meets certain criteria that would allow you then to maybe sit for licensure exams and things like that, right? So if you say, I'm a social worker, behind that is a specific set of knowledge that you come with. And I've just given some examples that I pulled from the National Association of Social Work's Code of Ethics about where that is mentioned when we think about that profession. Professionals also have to demonstrate a certain level of competence and be able to provide a certain level of skill, right, to things. And we have requirements within our professional organizations and bodies to maintain competence with continuing education and those sorts of things. Professionals are also charged with acting in someone else's best interest and not necessarily their own glory and gain. Now, obviously, hopefully we enjoy our jobs. They're rewarding to us. We find them fulfilling and meaningful, and they give us purpose. But we're not there just for ourselves. We're really there to take care of the patient or the client and help them meet their goals and be there for their best interest. We also, that's sort of a one-on-one commitment and duty. We also have a societal need that we fill as professionals. So for the overall good and well-being of society or the larger community. And we can kind of think of that tension between like the patient in front of us, who's maybe in the bed at the hospital, and the rest of the community who may need our services in the future, right? And then, as I said, professions set education performance and standards. And this also, you think about how we fairly and justly like evaluate students and trainees in our programs, how we pass along the profession to other folks, how we contribute to the future of the profession, both with research, right, including increasing knowledge in that area, but also with training students and setting what those performance standards are and that those are fair standards. And then lastly, there's that commitment to personal well-being and growth and development that we have. There's that saying, if you know, when you're getting on an airline, that you have to put your own oxygen mask on first before you help the person next to you. And so that part of being a professional is taking responsibility for that as well. All right. I want to shift to some virtues or things that help and facilitate that professional client relationship. And I'll probably interchangeably say professional client, healthcare provider, patient, because depending on where you're working, what type of health professional you are, those terms are used. So some of these that we think about that help facilitate care and meeting those goals and the best interest of patients are integrity, truth-telling, also called veracity, privacy, and confidentiality. So I'm going to take a minute and go through each of those. So integrity is to behave in a trustworthy manner, right? To be trustworthy. And we demonstrate that by acting honestly and responsibly, by keeping our commitments to our patients or clients, to our colleagues, to the profession, to the institutions that we work for, and thinking about state laws and statutes, right? So a number of layers of commitments that we have to keep. And by promoting ethical practice. So that's integrity. Truth-telling, we think about comprehensive, accurate, objective transmission of information. And why is this important, right? Out of respect for autonomy, so that it can foster that trust and understanding. It demonstrates our integrity, and it allows patients to make informed choices. So we need to give them all the information that they need in order to make a decision that's in their best interest as they define it. You think of situations where or is it ever acceptable to withhold the truth? And might there be cultural differences? And I'll say like capital C cultural differences and maybe small c, right? So thinking about, each individual person and family has preferences about how they like information delivered and how they want to communicate, right? So I'll give you a second if you want to just throw any ideas into the chat for when it might be acceptable, if it's ever acceptable to withhold the truth. And if you can think of some situations or preferences where that might happen. So I'll give folks a minute to do that. And if you just want to think in that right in there, that's fine too. So. I think it's an interesting question. Is it ever okay to withhold the truth? And is that the same as lying? Right? Okay. Another virtue that allows us to provide care. So when a person's life might be in danger, if we told them the truth, it might endanger them. It's a great. When holding the truth, what could be in danger, right? So we don't want to bludgeon people over the head with truth. People might want to have it in bits and pieces, right? Do we have to say it all at once? Maybe they want a trusted person there when they hear it. But potentially maybe someone doesn't want to know information, right? You could say, hey, I want you to talk to my daughter or my mom or somebody else, right? Other than me. You're allowed to defer that to someone else. Thanks, everybody. Okay. So shifting to privacy, the take home about privacy is it's related to access. So like who has access to information, right? So there are federal laws about who and how information can be shared, and that permission has to be given, right, by the patient to do that. So it could be just general information that's enclosed in your electronic health record. It could be physical location, like that you're actually a client at a particular clinic, right? That's private information. Where you're located in the hospital, that you're even admitted to the hospital, could be private information. Treatment choices, right? So the decisions you make about your treatment, that's private information. And then relational. So thinking about when and how things like HIV disclosure could occur under, when is that allowed and not? And the piece here is like, this is very important, right? I need to trust that when I tell information to my healthcare provider, that it's going to stay private, right? If I can't trust them, then I might withhold key pieces of information that then makes it difficult for them to treat me and makes it difficult for me to meet the goals that I have for my care. And so it's a balance as a healthcare professional thinking about how much information do I need? What information do I need to safely take care of this patient and help meet their best interests without asking information that I don't need, right? What's none of my business and what is, and that balance there. Okay, so that's privacy. And compare that to confidentiality. So confidentiality is a subset of privacy, and that's once private information is shared. So a patient shares information with me, they've shared private information with me. Now the standards of confidentiality apply. It's about redisclosure. Who can I, as a healthcare professional, share that information with? So it avoids violating that contract for the confidential relationship. So the difference between privacy and confidentiality, if an unauthorized person enters a hospital record, like you're not taking care of that patient, you're not assigned to them, you're just like, oh, I think that might be my neighbor. Let's go look, right? Don't do that. But that would be a violation of privacy. And then if an authorized person who has ability to see and is authorized to look at the hospital record discloses that information without consent to someone else, that's a breach of confidentiality. So you can see how all of these things need to work together, and when they work together, they help facilitate good care for patients. Okay, so thinking about Amy's case, what of the virtues that I just talked about might apply? You can, as you're thinking of them, does integrity imply truth-telling, privacy, and confidentiality? If you want to throw those a couple in the chat as you're thinking, what applies to Amy's case? While you're doing that, because of time, I am going to keep going. But all right. So let's shift to medical decision making here. So we've got Amy, who is unable to speak for herself right now, although we have some idea about her wishes. And we've got her family there. So talk about how that's great. People are confidentiality, integrity. These are great. Thanks, everybody. Okay. So the big thing is family wants information, and Amy can't talk or make decisions for herself right now. So how do we think about her care? So when someone is in a situation like Amy is, we'd say that she lacks capacity to make medical decisions. And capacity is a medical term versus a legal term. So competency is what we use for in the law. But in this case, we think about when you have capacity, you can make informed decisions to consent to or refuse treatment. Capacity is typically determined by a physician, although that can shift a little bit from state to state depending on state law. These examples are US specific. And then it's decision dependent. So I could have capacity to make a decision about an antibiotic, but not have capacity to decline a life-saving surgery, potentially. And it can fluctuate, right? So if I just had anesthesia, I might not have capacity. And in Amy's case, she doesn't have capacity. But obviously, if she were to recover from her illness, she had capacity beforehand, we'd anticipate that she would have capacity again. So it can move around. When you have capacity, you can give informed consent or refusal, and all healthcare procedures and treatments require that informed consent or refusal of the patient or their authorized representative. And healthcare providers are obligated to provide sufficient information so that a reasonable patient can make an informed decision. And there's that mutual participation and respect for autonomy of the patient that occurs in shared decision making. There could be some exceptions to informed consent. So in emergency situations, we don't have time for it, and we might treat. And sometimes under certain research protocols, there can be exceptions that are granted by the ethics boards. When someone can't give informed consent, because usually you have to be an adult to do that. So if you're a minor, or maybe you had capacity, but due to Alzheimer's or some other type of dementia, you don't have it anymore as an adult. Assent helps facilitate treatment, right? I have to at least physically work with the physical therapist and move my body when they're asking to do it, or that treatment won't be effective, right? So assent facilitates treatment that would be of value to the patient, even if they don't understand all the nuances or the details. Okay. So if you lack decision-making capacity, there's a number of folks who can help participate in that for you. So in the United States, a durable power of attorney for healthcare or a medical power of attorney, it can be authorized to make decisions. Each state has laws about who can make decisions if someone loses capacity. The court can appoint somebody, and then often it's family members or close friends, or maybe even healthcare providers who know the patient well that can help do that. And they're charged with making decisions according to the patient's previously expressed wishes or values. So in this case, Amy and what she might have expressed. And if those aren't known, then thinking about making decisions in the patient's best interest. So this substituted judgment that we ask families to use, or the surrogate to use, is act as though you were the patient, right? If they could see themselves and really participate in this conversation, what do you think that they would say based on what you know about them? And this is, so in that case, you have some idea, right, of what the patient would want. When you don't have any idea and you're more guessing, you're in the best interest standard. And so you're trying to give a preference to the patient's voice if possible, and thinking about the benefits and burdens of a particular treatment, the likelihood of recovering, and what would a reasonable person in a similar situation want. But you know less about what, this specific patient, like you've never had a conversation with them about what they would want for this situation. So in Amy's case, her parents and her family would act as her decision makers if she can't speak for herself. So she can go back to being her own decision maker when she recovers and out of the ICU, but currently her family would be in the role of making decisions for her if decisions needed to be made. All right. So let's say in this case, the person being asked, hey, tell us more, by the family is like, I want to get some advice here about how I should handle this. Because the tension is Amy has expressed that I want certain information shared, but her family might be in the position of having to make decisions for her, and they'll need good information to make those decisions, but there's some information Amy doesn't want to share with them. And could that compromise their ability to make a decision or not? So you contact the ethicist. What is ethics? So it's the study of and disciplined reflection on moral ambiguity. By that I mean when people are unsure what the right thing to do is, or they disagree about what the right thing to do is. And in our societies, we have a range of values. People bring those into these healthcare situations with them, and they have to try to make decisions, and they might reasonably disagree about what the right thing to do is. And so ethics is the systematic endeavor to try to understand those moral concepts. And pretty much you can think of many aspects of healthcare involve an ethical dimension, where we're trying to figure out what the right thing to do is, and how should we treat others. Just a brief note, legal and ethics are different. One of my lawyer friends says like the law is the floor and ethics is the ceiling, right? So thinking about sometimes we can think through history of things that maybe were legal at the time that we now in reflection think, oh, those were not ethical, right? And we can potentially think about things that are happening now where we'd say, just because something is illegal doesn't mean it's not unethical, right? And so trying to think about that. So it's good to know the law in the area where I work. I have to know it in my job because it matters. But sometimes you get to a different answer if you're looking at the law versus ethics. In healthcare, we often talk about 4 principles of bioethics, and those are autonomy, non-maleficence, beneficence, and justice. I am going to just spend a minute or two on those so that people are just using the same language and have a shared understanding. But these are often some of the frameworks that we use when we're thinking about the different factors that might be happening within a particular healthcare situation. So autonomy is at its heart a respect for persons, thinking about individuals should be treated as autonomous agents able to write their own story, and that persons with diminished autonomy are entitled to additional layers of protection. As a social worker by training, I think about autonomy and I think self-determination, the ability to write your own story, right? And as you define it and decide your own, what's in your best interest. But there are cultural differences, right? The autonomy may not resonate. I was talking with a group of folks, students in South Africa, and they're saying they really actually like the broader respect for persons because it's less, sort of individualized and more, it has a bigger sense for community and maybe thinks about relationships and how an individual is situated within those relationships, right? So there could be cultural differences on how we think about autonomy and the role autonomy should play in decision making. There may be limits to autonomy. I can't go around just demanding, doing whatever I want. I was talking to my 7-year-old and she's like, I can do whatever I want. And I was like, well, let's talk about that. Like, in the society, right? We can't actually just go around and do whatever we want. There are limits to things. And I can't compel like a doctor to give me a treatment that they think is going to hurt me, right? Although I think in broader American culture, sometimes we can think, oh, autonomy, I have to do it if someone else wants it, right? Like autonomy is sort of the king and trumps the other, like beneficence, non-maleficence, those sorts of things. And again, as we said before, it's the basis for autonomy and for informed consent and informed refusal. All right, beneficence and non-maleficence. So thinking about non-maleficence, first, do no harm, right? Protect people from harm. And then obviously we're going to healthcare because we want to help. So we're hoping that we can help secure well-being, right? Do better than just not causing harm. I think this is interesting though. Who identifies and defines what harm is and what benefit is? It doesn't really address like how should suffering be viewed? And thinking of those things. All right, so if we think about beneficence and non-maleficence, we have obligations to both. What's the stronger obligation, do you think? Do we have a stronger obligation to non-maleficence or a stronger obligation to beneficence? And if you want to throw what you think in the chat. I'm seeing some non-maleficence, which is a fun word to say fast. All right. Yes. So for those who were guessing non-maleficence, that is the case. So our first obligation is to not harm. Obviously, we do want to help, and there are many situations where we can. But in the situation I just gave where medicine could hurt. So I used to work with patients with advanced cancer. And at a certain point, chemotherapy would become toxic and harmful to them if we kept going. So we'd have to stop that. So you think about, well, I do want to help. my stronger obligation is to not harm them. All right, and then justice. And I'm going to do a disservice here because you can take a whole semester of a PhD course, on justice. But the general idea is thinking about who ought to receive the benefits or bear the burdens, and thinking about fairness and distribution or what's deserved. And I'll give the example of, let's say you're doing a research study and you recruit a group of folks and they're willing to take on the risk of sort of taking this unknown treatment. And then you say, okay, thanks, I got my information, and you go to an entirely different group of people once you sort of perfected and worked out the kinks and know how it works, and you give it to other folks, right? So one group bore all the burdens and a different group is getting all the benefit. And we'd say, okay, that does not seem just. So thinking about how we do that. And the balance in this case is thinking about the patient in front of me versus the system as a whole, and really advocating for that patient who's in front of me. And when we're thinking about benefit, we're really thinking about the return to an individual and not society. Again, how that return, that benefit is defined is unclear, and who defines it can be unclear. There are different theories of justice. And I'm just going to briefly touch on those. Like I said, this could be a whole course. But one theory of justice, utilitarian approach, would say that an act is just if it maximizes the good for the most number of people. So it could be bad outcome for me, but if it's good for the rest of the 26 people on this call, then we'd say, okay, that's a just action you could take. From a libertarian approach, a just action is one that optimizes or maximizes my individual liberties, so and autonomy. So if you're taking choices away from me or limiting my choices, that would be unjust. A communitarian approach is really a group, the community itself decides what is going to be just across the group. So thinking about distributing resources, a communitarian group would say, okay, how do we think we're going to maximize the good of this community? And maybe the community is, the folks on this call, or a group of classmates, or somebody at a particular job, if you want to think about community that way. And then the egalitarian approach thinks about how do we adjust action as one that allows the most people to have access to something. Just a brief example of this, and when we're thinking about the Affordable Care Act, and this is the ongoing conversation around the Affordable Care Act, and I'm really simplifying it, but for the sake of illustration, you can think, one of the arguments was it would be not a good program because it was taking from people, taking away from me, right? So you're taking taxes from me to make access for other folks. That's limiting my ability to provide for myself or things like that. So therefore it's unjust. Whereas the flip side of that was, hey, it's okay to take from those who have, to give a little bit more to allow more people to have access, right? But if you think, hey, this is how we're defining justice, and philosophically, we're defining it very differently, you can see how the challenges of that conversation could go. Oh, utilitarian, yes. Utilitarian says a just action is one that optimizes the most good for the most number of people. And you saw conversations around this with COVID and thinking about how we allocate ventilators and things like that, right? That it doesn't take into account like some of the nuances and piece, right? It's just thinking about most number of people and not so much thinking about access. Oh, you're welcome. All right. Okay, so I just gave you the principles, said, hey, we use them a lot, but they're not perfect. They're often in conflict with each other. So you can think about maybe beneficence versus autonomy, right? My obligation as a healthcare professional to help and not harm or whatever. And the patient saying, well, I want this treatment or not that treatment. You can think about withdrawal or withholding of that LST as life-sustaining treatment. So would you say, okay, I'm not going to offer a ventilator, or we're going to stop the ventilator, right? Think about resource allocation, what's right for the individual versus social or global justice. and how those can sometimes be in conflict with each other. So often more than one can be at play. They're not lexically ordered or weighted. By that, I mean, just because autonomy starts with A, it doesn't mean it's how you solve all the problems or it gets the most weight. And they can overlook the details. They don't really tell you like the contextual features of a case. Because of that, and this is busy, don't worry, happy to have them share slides with you, and I'll break this down. But this case-based approach has taken those 4 principles and tried to flesh them out with some questions to get at details to think through things. So, for example, box 1 thinks about medical indications that are happening based on the principles of beneficence and non-maleficence, and gives you some questions to think about and get clarity on, like, what are the goals of treatment? In what circumstances are medical treatments not indicated? Those types of things. Box 2 looks at patient preferences, the idea of respect for autonomy. Box 3 thinks about quality of life, drawing on beneficence, non-maleficence, and autonomy again. And then box 4 thinks about other contextual features, thinking about justice and fairness. Like, what are my obligations as a professional? What business interests might be in conflict? Are there religious or legal issues that could affect the clinical decisions? What about public health and safety and those sorts of things? So again, just to give you an example of how people have taken those principles and then tried to like make them very practical and applicable to specific situations. This is another framework, and I just want to give you a sense for like how people think through different things. And this framework, it starts with having to recognize there's an ethical issue versus maybe a human resource issue or a legal issue, although those things could be involved too. And then consider, who are the stakeholders? Like, who has a voice or a say in this, and how do we make sure all those voices are heard and we understand their perspectives and getting the relevant information? What more do I need to know to answer this question, right? And then thinking through, after I've gathered that, what are the various actions I could take? What are the alternative actions? And then they ask you to evaluate each action, each option, using these questions here below. For example, like, which action will produce the most good and do the least harm? So you can see beneficence, non-maleficence there. You can also see a bit of utilitarian like approach to justice. So you would do that for each of the different actions. And maybe one action, like action A, you can say like, okay, that works for questions 1, 2, 4, and 5, but maybe not 3, right? So maybe you can weigh things that way too. But in the end, you have to make a decision and you have to put it into action. And then I really like this model because it cues you to think about reflecting on that outcome. And then you can go back, if that action didn't end up with where you thought it should, you can say, okay, well, maybe we want to go back to option B and see what that does, right? There's just some ways to think about problems that we're encountering. All right, just a little bit more detail on ethics consultation. So you've called the ethicist, they've got these frameworks, you kind of thought about what are different aspects related to this case. So when an ethicist gets involved, try to help sort out, what the right thing is to do by thinking through who are the stakeholders, similar to that model we just saw, what are the different perspectives, really being very practical, like what will insurance pay for or not pay for, right? Because I can come up with a beautiful answer, but if there's no payer source, then we can't do it. So some of the different approaches ethicists have taken over time. One would be an authoritarian approach where the ethicist just comes in as the expert and is like, I know best, let's do this. Another option would be pure consensus, where they try to get all the parties to agree. Although sometimes you could wind out a situation that doesn't make medical sense or isn't possible. So pure consensus isn't always effective. And then the third way is ethics facilitation, where the ethicist comes in to try to help get clarity on what the issues are, facilitate communication, and integrate the perspectives of stakeholders. So I think this ethics facilitation is the approach that I take and that most ethicists take currently. And when we get involved, what do we do? So we help clarify the ethical question that needs to be answered. So people will be like, here's the problem. Or say, it sounds like this is a concern about your obligations to beneficence as the physician and the patient's autonomy, and how do we sort of balance those things moving forward. So they'll tell me clinical words around the clinical problem, and I'll translate that into an ethics language. So I try to identify the sources of disagreement, ensure that involved parties have their voices heard. And this is particularly important because you think about the power differential between professionals and patients, and maybe even within the healthcare system, between different roles and professions, right? Between nurses at the bedside and the attending physician and the intern who's the junior doctor, thinking about those different power differentials and how do we help make it as safe as possible for people's voices to be heard. And then we assist involved in the parties clarifying their own values. Sometimes, like, I've got that ick, like an ick feeling in my stomach, right? Something is bothering me. It's not right about the situation. It's not sitting with me well. But I need help getting to the root of like what is causing that unease or distress there. So we try to help folks sort through that, and then facilitate a comprehensive deliberative process, negotiate a workable compromise that makes good medical sense, and bring experiences from issues that we've been involved in the past to this one, to try to help reach a good outcome. So that's what we do. What we don't do is I'm not there to police clinicians, right? I'm not going around being like, are you being ethical? Are you being ethical? So I'm going on my rounds and things like that. I really, assume that we all came to work because we want to help. We're all in the healthcare profession because we want to help. We might just disagree on what help means or how to do that best, right? I'm not there to make moral judgments. By that, I mean, I'm not saying that one particular person's set of morals is better or superior than another's, right? If we came with different philosophical approaches to justice, right? I'm not there to say, oh, you're more superior than another. More about respect for people. Yeah, we can definitely talk about that when we're talking in the question and answer. So I'll come back to that and remind me if I don't. Okay. I'm not there to dictate choices or take sides. So I'm not there, like I say, like I'm always on the side of the doctors or I'm always on the side of the patients. We're really trying to sort through into like, in this particular situation, how do we proceed? And I want to really support that doctor-patient or clinician-patient relationship. I don't act as legal counsel. And if there are clinical disagreements, like one team feels like, oh, the right thing to do would be provide this antibiotic, and somebody else thinks, oh, we should do this other antibiotic, for an example, I don't have the expertise to wade into that. That would have to be figured out within their own group about experts for infectious disease. All right. So then what do we, how do we decide what to do? So we think about like the different principles that might be involved, the different virtues in this case, sort of the capacity concerns and making decisions. How do we figure out what are we going to tell? In the end, we have to say something to Amy's parents, right? So what are the ethically appropriate actions available to us? What I think is interesting about ethics is it usually can give us a range of appropriate things, right? It's not like there's one right answer. There may be some preferable things and some things we really don't want to do, or maybe a wrong answer, don't do X, right? But in the middle, there could be a number of different ways we could proceed that could be ethically justifiable, that could honor autonomy, that could meet our obligations to beneficence and non-maleficence, right? So in thinking about Amy, some of the things we might want to consider are what information needs to be shared right now. Are there any medical decisions that need to be made? Or could this be more general, right? How should we prioritize our professional obligations at this time? So the obligation to autonomy versus non-maleficence, beneficence, how would you weight those at this point as we know the case to be, and how could those shift, right, as her clinical situation shifts. If the patient hadn't said, "Don't tell my parents," like let's say Amy hadn't said that, would that change our approach or our professional obligations to the patient? And if she were 17, right, versus 19, so a minor for most of the places in the US, would that change our obligations at all? So I think those are some of the things I think about for her case. And we can definitely take that into discussion. I'd love to hear people's thoughts on what to do there. So I can tell you what did happen in this case. It's been anonymized, so but I think in this case, the way we would typically handle it would be providing more general information and just letting them know, like, she had a complication with surgery, right? And that's why she's in the ICU, without having to go into details of like what all of that was. And then if she were sicker and it became really important to know really detailed information for her family in order to make decisions for her, then we'd have to reconsider what information gets shared with her. Obviously, if she woke up, then we want to tell her what happened, if we had to be more detailed. But I think in this case where it is right now, it would be general. We could explain, hey, we have obligations, both legal and to the patient, to we can't really share detailed information. And I try to normalize it, that it isn't just about her or because something, scary or something happened to her that we're withholding information, but more just generally say, I'm happy to share with you what I'm able to based on the law and our obligations to privacy for her and confidentiality. So, and they might have feelings around that, but then we'd want to support them around those feelings, but that doesn't change my obligation to share things. And then lastly, if she was hadn't said, "Don't tell my parents," those legal protections, our ethical approach to it, those still apply, right? They shouldn't have to say, "Don't tell my parents." It is private information, whether she says that or not. And if she was 17, most states have laws about privacy related to reproductive health. And so, at least in our state, in the state of Michigan, that would still be private information at 17, even though she'd be a minor. But that could change a little bit from state to state. All right. I'm going to stop sharing, and then if folks are comfortable, we'll shift to questions and answers.
I have a question.
Yes.
So, and this is, it's kind of, I don't know, I feel weird asking because I did spend 6 years working in a hospital, but it was long ago.
Okay.
But even though, like, if, like, let's say, she walked into the hospital, so that was that scenario. But at what point does it change if, like, let's say she were in an accident first and, like, there was never that communication at all, but her, they have access to speak to her family. So at what point, like, where is that line between, patient confidentiality, but also informing her family so that they know what's going on? Does that make sense?
Right. So if she came in and we were like, we had to call her family to say, hey, she's here at the hospital.
Yeah.
If she, I think we would say, you are trying to balance that privacy and confidentiality, but also, like, if we don't even know much about her and we don't have anyone to make decisions for her, like, it's still in her best interest more globally to have someone who knows her be able to speak in and make decisions. And in an emergency, we'd probably start treating her, right? But we'd pretty quickly contact her family to figure out who can speak on her behalf and make decisions too. So I think that like that tension between the privacy confidentiality, but also needing input, and not being the people who are making all the decisions as the healthcare team. So I think we'd probably contact them. Again, if you're the surrogate, I was thinking about, like, you need the necessary information to make an informed decision for that decision. It's not like we're going to print out her whole medical record and be like, here's a book, you can read it, right? Like, so
that makes sense.
yeah, so it's not carte blanche to the whole access to the whole record. It's needed
The
information for
necessary
this
information.
decision. Yeah.
Yeah, that
Yep.
makes sense. Thank you.
Yep. You're welcome. And then something in the chat. And then
I can help reading the questions for
yeah,
you.
thanks. Okay.
Yeah, for sure. So we had a previous questions before, but can you go more into about the respect for people and their bodies? Can you speak about the advocacy for them and preparing women and people in general for procedures?
Oh, okay. So Kayla, I don't know if you have more you want to say related to that question too. Yeah, so I think we think about bodily integrity and like person and not trying to we want to engage people, right? So if you have capacity, engaging you and understanding what's happening to your body so that you can, or the treatments we're offering, what would happen to your body if we did treatment A versus B, and respecting that, and people being able to say, yes, I want that, or no, I don't want that. And people with capacity can refuse treatment, even if it means that it's going to lead to the end of their life. But we really want to make sure that they understand that, right? But I think even for kids, like I was thinking about my children, and so I have an 8-year-old, a 3-year-old, and a 2-year-old. But when I'm taking them to the doctor and the doctor's engaging with them, like understanding about their body and what's happening to their body and having as much say as they can is super important, especially as I think about how they continue to interact with healthcare as they get older too, right? So that body safety is really important. And I see this in my, even if you don't have capacity, like you can still tell me things about what you're experiencing, right? Like the symptoms I'm having. And we can engage to that point. Like this, again, this is the law, but when a court appoints a legal guardian for a patient, so that's basically saying the patient can't make decisions for themselves. That guardian by law is still supposed to engage that patient in decisions to the best of that patient's ability and to try to support that patient in being engaged as possible in what's going on. So I think there's still this piece of, even if you don't have capacity or are deemed incompetent by a court or a child, that your body, you have some ownership over your body. And there's certain things that we're not going to do because that would violate that piece. So the last thing I'll say is the nurses I work with are amazing, but thinking I'm often in our intensive care units, and these are patients who do have the ventilator, so they have like the tube and they're asleep, right? Often like not awake and alert. And even then, the nurse is saying, hey, Mr. Smith, I'm going to turn you this way. Hey, Mr. Smith, I'm giving, like, they're very much attuned to the, humanizing and the dignity and letting that person know, like, hey, I'm just going to touch you on your shoulder now, right? All those sorts of things, even though that person's not very awake, because you never know what someone can hear. And you want to be really clear, like, you're respecting their body.
I have a quick question about the case.
Yes.
So let's say, for example, something awful happens and Amy doesn't make it. Are you able to tell the family the full details of why she was in, what was going on, all of that? Or do you still respect Amy's wishes, even though she's no longer
Yeah. I mean, I think some of that information is still private. It's like, how much do they need to know at that moment? They would have, they'd have ability to access her records after she's died too. So I think there's I'd want to respect still how we share information and what information she wanted. And that, like, it would be up to them then to take that extra step versus me, personally telling them all that information.
Okay,
But
thank
you can
you.
imagine like that was going to be really hard for the family potentially. But yeah, I think you could try to figure out how you would share information that is as respectful as possible to her wishes, but gives them information that they need to know.
So would you suggest having them like look into it, or would it be more emotionally bearable on the family to just tell them versus having them go in and find out all that medical stuff on their own?
On their own. I think you could argue for both, and this is going to be the dissatisfying answer. Like, is there a right answer? I think like depending on who's all involved in that situation as you're talking with the family, I think you try to figure out like how can you help alleviate the distress, what information would be helpful right now, versus them getting hit over the head with it. And at that point, I think you are trying to share some level of information. Like they could ask for an autopsy, right? And get information. The results of an autopsy are always shared with them. I've definitely been in situations where when the autopsy results are returned, the family has come back to meet with the team to go through the autopsy results. So in that case, like that would be clear. If they get their records, you could also offer to say like, happy to talk about those records, like too. So,
Okay, thank you.
yeah. I mean, I have
Perfect.
situations where we've never shared that someone has HIV, for example. The family that's never been shared with the family, they don't know because the patient would not want that shared.
Thank you for answering all this.
Yeah.
We do have another question here. What advice do you have for high schoolers that want to become a doctor?
So I'm a PhD doctor, not a medical doctor. So I think there are lots of different ways, but I can talk to my PhD doctor guy. Uh, I do think it's helpful to get like exposure to different types of healthcare situations. So a program like this is really great because you can hear different perspectives because there's so many different ways to be a doctor, whether that like an MD, but also PhD. There's very different ways to engage within the healthcare system and have impact on patient care. So I do think when you can hear from different stories, and just because you're like, oh, I'm not sure I'd want to be, a surgeon, or that doesn't mean there isn't actually another type of doctor to be.
Perfect. Thank you. Another question in the chat. Can you describe a situation where you or a colleague of yours have made a medical decision and messed up, and how did you deal with it and move on?
Yeah. Yeah. So I don't practice medicine myself, but there are situations where I think, all of us make mistakes. All of us are still learning. And so, and those mistakes do have consequences too. So trying to think about how we handle those. But I've definitely thought, one thing was going on in an ethics case based on the information I had, and then get more information later and go, oh, I actually missed a key stakeholder position, or we didn't have all the information. So I think part of it is in humility, like being gentle and having mercy on yourself, right? Like I'm allowed to have an off day or make a mistake, or I was trying as hard as I could, and I did the best that I could with the information that I had. And now that I have different information, I'm doing differently. And then also like, who do I need to talk to? So I've definitely gone back to patients or families or colleagues and said, hey, I was thinking X, but now I got this other information, and the advice I gave you yesterday, we're gonna have to change that. So having those kind of transparent conversations. And I think for when it comes to patient care, like just being straightforward, like, hey, this happened, and here's the next steps. Here's what we're doing to make sure it doesn't happen again, right? To other people, and what questions do you have? How can we support you through that?
Perfect. Thank you.
Okay.
Another question kind of similar to this, but is there ever a situation where even not a clear solution is there available? And as you as a professional, how did you deal with it, especially taking a non-ideal decision?
Yeah. So in ethics, we call that the least worst decision. There's not like a good decision. There's just the least worst decision. Maybe just humans call it that. Not necessarily ethics, but yeah, sometimes it's like, I've been in situations where there isn't resources for that, or insurance won't pay for something, right? Or all the things we're doing, everything human hands are doing to try to cure the patient or, fix the thing, right, are not working. And sometimes it's like in the face of suffering, right? Someone's suffering and the medications we're using to treat the pain aren't working the way we're hoping they would, or whatever that might be. Then thinking about how the ways I can help, or being present to folks by acknowledging that, like, yeah, this is a really hard situation, and maybe nothing unethical is happening, but it doesn't mean it feels good, right? You could say this is ethical, but the system has so many limits in it and holes in the healthcare system, and so it is not possible always to get the outcome that we want.
Perfect. Another question, can you please provide advice regarding returning to health field after almost 10 years? Even non-clinical and administrative positions are difficult to step into.
Yes. I think getting into a system can be really hard. And just like, can I get in anywhere and start to get some sort of history and credibility within an institution can be challenging. I think where I've tried to think, like, I have some folk, trying to, or they're volunteer positions. Obviously we need money to eat, right? Eating is important. But trying to think, while I'm doing one thing to earn money, there's an opportunity for some volunteering, for some committee work, for patient family advisory participation. Just trying to think, are there other sorts of things that way within the healthcare system? We have community members on our ethics committee. It's just trying to think of people engaged there. And then I don't know if you're near centers where trying to help with from a research standpoint too, with research projects and things. Sorry, Kay, I can't. I'm happy to be happy if you want. Okay, if you my email and chat more offline if you want to do that. I can type here. I'll type it in here. Folks are welcome to email me too.
Thank you for that. It's difficult, and that's pretty much my brain every day. When I'm trying to figure it out, I'm like, what does that really look like? So,
yeah. All right. There's if folks do have questions, I'm happy to answer.
Thank you for sharing that with them.
Yeah.
Okay, we're gonna move on to another question. What are minors who meet the age of consent allowed to consent to, or when it comes to medical decisions about their bodies?
That's a great question. And my answer is it depends on what state you're living in, at least in the United States. There's a range of things. Different states have different laws. I know, like in the state of Michigan, minors can, starting at 11, have some privacy and confidentiality around reproductive health, substance use, mental health issues. And then obviously, so from 11 to 17, there's range there. You can seek care on your own for those things. Not every state has that, or they might draw the line at a different level. That's different from emancipated minors, who the state has said act as though they are adults around their own decision making, and how that gets decided is a little bit state specific too. The American Academy of Pediatrics does have some general guidance, so that says that if you are developmentally 14, so not chronologically, so you could have the maturity of a 14-year-old but be 12. You could have, but when you're around developmentally 14, that you should have a voice in your treatment, and that voice should carry weight. Now, that it's a bit of a sliding scale, though. How much weight do you give it? More weight for smaller decisions, and how you think about if it's like a life or death decision. The parents still have the ultimate say there, but there's an obligation to sort of say, like, this person has what we call emerging autonomy, and should be included in their voice if they want to be included. again, we're not there to force people to be included if they don't want to be, but that 14 is kind of a big cut line. And some states would think about, if you're 7 versus 14 versus kind of where you are. But AAP throws 14 out there.
Perfect, thank you.
Yeah.
I had a question about how do you think your professional, like as a general, like your work daily job is very diverse and inclusive that would prevent the stress or the anxiety that comes to patients overall.
Yeah. So my job, because I work in an academic medical center, is both it's got research, it's got education, and it has the patient care piece. So I get to do all of those things, which keeps it very interesting for me, because even if one's hard, you can like focus on another one for a little while and you're never bored, you shift through them. Day to day, my job looks a little different because of those things, and questions that come from patients and families and teams about ethics can vary. And I cover adults and pediatrics and inpatient and outpatient. So a wide range of things that come, but I like that because it keeps it interesting. We do get, ethics, I think, gets asked to weigh in on some of the most difficult cases in the entire hospital. So they're hard that way. Like people are going through some really hard things when we're like in often complicated things where the right thing to do is not clear. And so there is a bit of bearing witness to a lot of, distress and human suffering. And the teams are distressed too, because they want to help, but they're struggling with figuring out how to do that. So that there's that and a lot of emotion. It's a very emotional job in those ways. On the other hand, I feel like I've got good training and that I'm equipped really well to do that. And I think having a good team is important. So I work with a number of other ethicists. Some hospitals, ethicists are by themselves, but in my hospital, we've got a number of different ethicists. So it's really good. We meet every week to kind of talk through cases where we can reflect on how it's impacting us as well, too. So I think that's like on the job, I have good support and opportunity to think through and reflect on how the cases are impacting me. So that social support is a really good antidote to burnout and distress and that sort of thing. And then I think I've just developed skills that I can be present to how hard it is. I'm there. And like I have emotions around it too, but I don't feel like I take it home with me. And I built a tolerance, not that I feel like I'm jaded to it, but a tolerance where like I can carry that and hold that space without it being devastating personally to me, that allows me to still be effective with patients. I also like to travel a lot. So like that's the balance, right? Like and I try to take good time away from work and keep that boundary there. Spend time with my family. Like I said, I have my 3 girls, and so and my spouse, and we like to good family time together. I love to read. I'm a sometimes yoga person, sometimes running, sometimes none of those folks. So yeah, just having some hobbies and things and relationships that are good outside of work, but also good relationships and colleagues at work can help balance a hard job.
Perfect. So what if someone in your professional, like having that trouble of doing the balance, what would you have like the on-go advice for them?
Yeah. I think all of us struggle with that balance from time to time. And I know one of my personal struggles is especially like when I'm having a slow week or a slower week, I think, oh, I have all this space. I can say yes to more things. And then I say yes to more things. But then on my busiest week, I don't have time for that. Right. So in some ways, I don't modulate that for myself. So one of the things like I do is actually have someone I check in regularly with and have regular meetings. Be like, does this sort of the things I'm committed to right now at work, does that make sense? And then also when I'm making a decision to say like, on my busiest week, would I have time for this? Because that's really the question, not the slowest week. And I've definitely sat in, it's something that is taking me, I've been doing this for 20 years, some time to get right. And definitely at the beginning, I remember I go into my boss's office and be like, I did it again. I think I need help figuring out like what are the things I need to keep here. I also think if you feel like you are taking work home with you a lot, that it's an opportunity for some reflection about like, is the right job for me? Am I taking on more than I need to? Is it that I don't trust my teammates to like cover the shift when I'm gone? Do I somehow think I'm the only one who can do it for the patient? Right. I think there's a lot to dig in there, but having a trusted friend, and I've definitely had met with a therapist over, at various times over my career too, to say like, how's this impacting me? What's this bringing up? Like, why do, what do I feel like I can't set this down or let go, or that balance for work? I will say having my spouse is a good sort of like thermometer too. He'll be like, this pace is not working too, right, for us. So just trying to like, who are your trusted people who can say that to you? And then do you have good, having those relationships at work where you can say, okay, if this isn't working, if I'm not hitting that balance, how do we get back on track?
Perfect, thank you. Another question I thought about, like to have good qualities in person, just anybody that goes into healthcare is important. So what qualities do you think a person who wants to go into healthcare, whether as a doctor, as a PA, as a medical assistant, as a nurse, or whatever it is, to have so that they're able to have that very good skill or whatever they want to provide to patients to do?
Yeah, I think, medicine or doing healthcare, it requires teamwork, right, and collaboration. And it's a really busy environment, and it's a complex system, and there's a lot going on. And, it's patients' worst day usually too, right? So they're not bringing their best selves either. And so I think being a good communicator is like to communicate with your colleagues to make sure everyone's on the same page, has a shared understanding that the patient and family. So communication is both speaking, right, and the information, how you relay that information, but it's also listening. And so I think from patients and families, being able, like that listening piece, and demonstrating that you want to hear what they have to say, is really important.
Perfect. Yeah, then that's all the questions that I personally have. But does anybody here have any other questions or any concerns? You can go ahead and put them in the chat, or you can unmute yourself and feel free to share them.
I'll just briefly just say, so how does one become an ethicist? So there are lots of different ways to be an ethicist. So ethicists will sometimes be PhD philosophy trained, but they all different kinds of physicians will do it. Some of the ethicists at my institution are surgeons. One of the I've got lawyers who are ethicists within the healthcare system. I've got pediatricians. I've got someone who's a palliative care provider. I have someone who's in pathology, right? She's a physician in pathology, and she's an ethicist. So I think you can be nurses are ethicists, right? I've got a chaplain who I work with who is an ethicist. So there's not one way. So most people, when they want to move towards being ethics, will get some work working with an ethics committee and doing ethics consults. You can get formal training too. You can get like a master's in bioethics if you want. But there is, in the end, you spend enough time doing it, about 400 hours, you can sit for the healthcare ethics consultation certification. And that's what most of us hold now for doing the work. So there's lots of roads to it, not just one way. And every hospital is required to have, by Joint Commission, required to have a way to address ethical concerns. So it looks like a big team at my academic medical center. It may be a sole person at a smaller hospital, but everyone's required to have a way to address ethical concerns.
Perfect. Thank you so much. I personally have learned a lot throughout this presentation, and I'll take it with me to my daily work in school. So thank you for that. And I think, thank you. And then, so Vanessa, you can go ahead and share your closing slides.
Thanks, everybody. I'm going to just shut my camera off while it says that. And happy to take emails from everybody. And thank you so much for inviting me.
Thank you, everyone.
Yep, please give me 1 minute. Okay, guys. So this is the wrap-up portion. If in the chat, if you would like to share these 3 questions, what brought you to the session today? What are 3 major takeaways you got from this presentation? And what do you want to learn more about? I'll give you a minute to write your responses in the chat. Okay, well, okay. If you would like some recognition, you could write a reflection about what you learned in this presentation with this Google link. If you want to be a part of pre-health shadowing, you could become a volunteer like me, or you could become a pre-health shadowing team member. Some team member positions are like fundraising, volunteering, and stuff, and make grants. So if you have experience and want to help this organization, make sure to join. And also, this is of course student-led, and it's all volunteer work, and it's all for free. We have a mission of giving free medical shadowing for everyone. So if you would like, you can donate, and we would really appreciate it. Lastly, you could gain your shadowing hours by doing the quiz on our website. It's pretty simple. It's a 10 multiple choice quiz. You have 2 chances to pass, and if you get over 70% or higher, you can get your certificate for your virtual shadowing hours. Quizzes are open indefinitely, but make sure to do them. And if you missed part of the session, don't worry. We record all our sessions on our YouTube channel at Pre-Health Shadowing. So make sure to check them if you have any questions. And on our website, we show all our upcoming sessions. So make sure to catch them every week if you like shadowing hours and want to hear perspectives from professionals. So thank you guys for coming to Pre-Health Shadowings. If you have any questions, feel free to stick around and we'll answer them. But you guys can leave now.